Bismillahirrahmanirrahim. Assalamu alaikum and good morning everyone. Welcome to the session on the conservative aesthetic procedure. From today, our topic of discussion will be exclusively about the clinical aspects of the aesthetic dentistry. So, as a part of series of lectures on aesthetic dentistry, we have completed the fundamental aspects of aesthetic dentistry. A quick look back to what we have accomplished till now. We understood the aesthetics along with its components, the philosophy of color in dentistry, adhesion to the dental hard tissues and composites were discussed in detail. So from onwards, we will be focusing on various treatment modalities for aesthetic demands of the patient. But before we move any further, it's important to look at various clinical conditions which usually presents with aesthetic demands. Understanding these conditions from its biological, pathophysiological perspectives, helping us in determining the best treatment options for any given conditions. So, there are certain clinical conditions. Some of them are non-invasive, in which we can remove without removing the tooth, and without grinding it we can achieve the results. Some got invasive results in which we have to remove the tooth structure, and some are the combinations in which we have to keep the both sides on the same formulation. The clinical conditions in which there are discolorations are KDs, it can be a trauma, it can be MIH, molo-incisor hypomineralization, it can be fluorosis, and it can be tetracycline stains. So beginning with the basic discoloration, most of the times the patient complains for discoloration. Oftentimes this is a simple complaint that is a consequence of a multitude of problems such as previous failed treatments, secondary caries, pulpal exposures, unnecessary tooth surface grinding, or the natural tooth surface loss. It is imperative to rule out in the beginning if conservative treatment is ultimate treatment, or a combination of conservative treatments along with invasive treatments may be required. As you can see in the picture, there are multiple restored teeth and we can see discoloration. Maybe that is because of the unpolished, unfinished fillings, maybe poor oral hygiene, and maybe from the dietary chromogens. This picture is showing us the fluorosis. Fluorosis may occur when there is a chronic and excessive exposure to fluoride during the years of tooth development. Fluoride is a naturally occurring mineral in water, although some regions have higher levels than others, and in some areas fluoride is added to water supplies in low levels to help prevent tooth decay. Exposure can occur via bottled water and fluoride toothpaste. In the mildest form, fluorosis appears as small opaque white flecks on the natural enamel surface. More severe conditions show severely hypoplastic patches of enamel, which are vulnerable to accumulation of surface stains. Chronological fine white bands of fluorosis may be seen that corresponds to the time of higher exposure of fluoride. I will request you guys to have a look on Dean's classification of fluorosis to check for the severity. According to the scales, we can manage them in the startup scales like 0.5 and 1 Dean scale. We can treat them with non-invasive methods, but while the grade improves, we have to go with the invasive options. These are the white spot lesions, also defined as white opacity, occurs as a result of subsurface enamel demineralization that is located on smooth surface of the teeth. These white spots are more resistant to bleaching as compared to the brown one. If you bleach a brown and a white spot, the brown spot will leave early while the white spot will play a trick and it will take some time to be gone. The brown stains They may be caries, they may be residual caries, and they can be the secondary caries, and they can be the chromogens from the food particles or even from the mouthwashes. There are staining particles in the mouthwashes as well. So these stains should be conclusive before either they are caries or chromogens and just a layer on the enamel. In this picture you can see the dark bands, so we can classify it as a tetracycline stains. Tetracycline is a broad spectrum antibiotic and its derivative minocycline is common in the treatment of acne. The drug is able to chelate calcium ions and is incorporated in teeth, cartilage and bone. Ingestion during the years of tooth development causes a yellow-green discoloration of dentine, which is visible through the enamel and fluorescent under UV lights. Later the tetracycline oxidizes and staining becomes more brown and no longer fluoresces under UV light. The most common period of tetracycline staining is 2 to 3 months in utero and 2 to 3 years after birth. Dental caries, also called tooth decay, begins as an opaque white spot on the surface of the enamel. Such white spot can be remineralized as they are the demineralized part. As the demineralization progresses, the various lesion eventually cavitates and the underlying brown color become visible. So trauma. Generally there are 3 types of discoloration. We can call them the pink, yellow and the dark discolorations. The pink hue may represent either internal hemorrhage or an internal corneal resorption known as external invasive cervical resorption. It can also be seen in internal resorption. Yellow discoloration usually represents pulp canal obliteration and calcific metamorphosis as a result of the reparative dentine formation, and the dark discoloration is the most common reaction to traumatic dental injuries. Such diastemas are considered to be the luck sign by many people around the world, but some people have high concerns to get them filled, and according to them they look odd in their smile when they have diastemas. Some diastemas can be closed by simple veneers rather than making crowns or bridges, which is extensively invasive. But to close them with composites, we need to measure, and there is a record line up to them. We can close them. Like if there is 2 mm of diastema, we can close them directly with the composites, but if it's more than 2 mm, then unfortunately we have to go with the extensive options. This very picture is showing us the molar incisor hypermineralization. As you can see the paring and defects on the picture, and the indication lies when you screen out the patient and the molars and the incisors are severed, but the premolars are usually prevented and they are normal. As you can see in this picture, this is a maxillary picture. The premolars are normal, the incisors and molars are affected. Similarly, going for the mandible, the incisors and molars are affected, but the premolars are prevented and they are good. So these MIH patients have a high protein contents in their enamel and have a different proteins as compared to the normal individual. So they go with the rapid breakdown, also known as pre-eruptive breakdown. Soon after they erupt in the oral cavity, the enamel start disrupting and the outer layer is gone, and the patient presents with sensitivity. The major concern is sensitivity, aesthetics and rapid tooth surface loss. So we have to manage them step by step. These were all the clinical cases, conditions in which we have to think about and talk about the invasive and non-invasive options. Certainly it is a mixture. Sometimes we have to go with non-invasive options, and otherwise we have to go with invasive options.
A high quality and attractive smile is fast becoming one of the main social needs amongst today's population. As you know, guys, you daily watch the television advertisements and you see the cover page of the magazines. And when you see Angelina Jolie smile with the beautiful teeth, you wish to have the same smile and for that purpose you always go to the dentist. So we are the proud guys that we help to improve the smile, and we are happy with that. So guys, as with any therapeutic treatment, proper diagnosis should be attempted before a course of treatment. It means you have to diagnose before plan of any procedures. Although the etiology of a specific tooth discoloration may be difficult to recognize, for that purpose you have to ask the patient about the history. And obviously there is evaluation of the factors also will be there to help in establishing a differential diagnosis. The presence or absence of pulp tissue is also a treatment planning factor, because when there is a pulp, you have to be very secure because there might be a sensitivity problem in that case. If there is no pulp, then obviously sensitivity will never be a complaint. Even with definite diagnosis, however, the ultimate outcome can be unpredictable. So the conservative options we have, they are non-invasive. There's a vital bleach and prepless veneers. So in case of vital bleach, obviously the vital means the pulp is there. So you do apply some bleaching gels on the dentitions and to improve the color of the teeth. And in case of prepless veneers, you don't need to prepare the tooth. You don't have to remove any enamel. You just have the veneers manufactured from the manufacturer and just to have to apply it on the teeth. So it's a non-invasive one because you are not doing anything with the dentitions. Then we have other options as well. We have microabrasions, we have resin infiltrations, then we have a macroabrasions, then direct composite, recontouring, combination therapy, direct and indirect veneering. These are all invasive one, and we can say it's a minimal invasive because you remove the enamel, but in a very limited amount. So guys, in acid, in all these procedures, we apply the acid actually, and acid helps in mechanical abrasions. Acid abrasion techniques are efficient because of the short treatment times, because it involves the removal of enamel. It is limited to the most superficial discolorations. It means that zero point 0.3 to zero point 0.4 enamel if involved, then we go with microabrasions and the macroabrasions. Uh, then we have resin infiltration therapy. This too involves the use of hydrochloric acid but includes the addition of the resin. Actually, we have to penetrate the resin to the lesions, and which has been successfully used for refractive index modifications in white spot lesions. And guys, remember that white spots are very resistant to the bleach. So if you apply a bleach and to improve the white spot color, it's impossible with the bleaching. And guys, it is believed that the resin alters the light refraction behavior of the infiltrated enamel to mimic the surrounding healthy enamel. And then we have a combination therapy, the use of bleaching techniques and acid applications and mechanical abrasions consecutively may provide the desired clinical result in some cases. Then we have invasive options. Obviously, when you have a large class 3 and class 4 lesions, very common lesions, and the patients present to you most of time with all these cavities. Then we have a non-vital bleach because it's invasive. Why it's invasive? Because there is no pulp and we have to place something inside the tooth. And obviously, there is some problems with the bleaching gels in case of non-vital bleaching. Then we have inlays, onlays, overlays, crowns and bridges where we remove healthy enamel and dentine. So guys, these are very invasive options. So we will consider them after minimal invasive and non-invasive options. If they're not working, then we will consider the invasive ones. So let's talk about the most complained clinical situations. Apart from the shape, symmetry and alignment. Obviously, a lot of patients present to you with the normal dentitions. They have normal shapes and normal symmetry and normal alignment of the teeth, but they have brown spots and the yellow spots and the white spots in the teeth. So they only present to you to improve the color, and everyone is right in that aspect because everyone want to improve the smile, and that's a very healthy demand from population nowadays. The color or shade of the tooth obviously play a very important role in overall appearance of the aesthetics. So the types of discolorations, it might be intrinsic one, it might be extrinsic one, and the combination of both. Intrinsic means it's basically in the dentine. The discoloration is in the dentine. It's by birth, like tetracycline staining. And if you're living in some area where the water is basically full of the fluoride, so you will get fluorosis there. And then extrinsic one, like tobacco smoking, and if you're chewing some pan and tambaku, so all these things leads to the extrinsic discolorations. And combination of both, it means that sometimes the patient has intrinsic one and extrinsic one as well. So it's very difficult to find the reason of discolorations. For that purpose, you have to ask about the history of the patient and the relatives as well. So tooth discoloration varies in etiology and appearance and localization, severity and adherence to tooth structure. It may be classified, I told you already, that intrinsic, extrinsic, and combination of the both. Intrinsic discoloration can be defined as discoloration which is incorporated into the structure of enamel or dentine. It means that it's not superficial stain, it's always inside the dentine. So for that purpose, you cannot do the microabrasions and the macroabrasions. You have to go to some other options as well. And these intrinsic stains cannot be removed by prophylaxis with toothpaste or pumice. You cannot remove all these discolorations with some abrasive toothpastes, and a lot of the patients ask us about how to remove these stains with a paste. It's not possible with that. Intrinsic discoloration can be significant, cosmetic, and some instances functional problem as well. Loss of vitality secondary to trauma or infection frequently results into discolorations because there's a bleeding and the tubules just filled with the blood, and that discolorations appear through enamel. So that's basically a reason behind discoloration you always see in patients with a history of trauma. And this thing is not responsive to conventional endodontic therapy. You cannot improve the color with the root canal. You have to do some bleaching with the root canal as well. Similarly, fluorosis, tetracycline staining, and localized and chronological hypoplasia, and amelogenesis and dentinogenesis imperfecta, where enamel and dentine both are not perfect. So they always appear in the clinics with loss of the enamel and dentine and lot of the wear on the dentitions. And obviously, when you have a wear, when you have a discolorations, when the enamel is not there and the dark brown dentin is visible, so it produces a very bad results when the patient smiles. So systemic disease like bilirubins, congenital porphyrias, drugs like tetracycline is a very important medications most of us use when at the time of younger age. So that leads to discoloration as well. So what are the local causes, guys? It could be caries, internal resorption. So it's a very always remember that the very important sign for internal resorption is the pink hue that appears through enamel. So but for that purpose you have to understand why that pink hue is appearing. And then metallic restorative materials like amalgam. When you have amalgam from 100 years ago, and the patient just present to you with some black discoloration of the gums, obviously it's a very important drawback of the amalgam. So we call it amalgam tattoo, like that thing. So necrotic pulp tissues, obviously the pulp when it necrosed, there is a discoloration appear in the dentition. So for that thing you have to evaluate the history and radiograph of that patients. Root canal fillings, we always recommend just remove the gut upperca below cement enamel junctions, because the remnants of the gut upperca always appears as a brown discoloration. So for that purpose you don't need any microabrasions and macroabrasions. You have to follow the rules of doing any procedures. So, as we told you in the previous slides, there's a type of extrinsic discoloration. So, it might be because of tobacco use and poor oral hygiene. When the patient don't brush the teeth on a daily basis, the plaque can discolor with the passage of the time. So, and gingival hemorrhage and chlorhexidine is a very important irrigant we use in the clinics, and the mouthwash as well. It also leads to discoloration. So we have to be very secure about all these things when you ask the patients about the reason of discolorations. Moving towards the conservative aesthetic procedures, and we are going to start off with the non-invasive treatment options such as the vital bleaching. So today we are going to discuss all about bleaching, which includes the vital and non-vital. Bleaching systems also can be used to treat superficial staining and are the only technique available for deeper enamel stains and for staining of the dentine. Repeated treatment application oftentimes are necessary. Vital bleaching is accomplished either completely in the dental office or the power bleaching or outside the dental office called the home bleaching. Non-vital teeth can be bleached with an intracoronal technique or inside-outside technique. So, in talking about the indication, uh, the bleaching is not indicated for every discoloration. Having said that, mild and generalized staining, age-related discoloration, and very mild form of fluorosis can be treated with the help of vital bleaching. Acquired superficial staining, stains which are related to smoke and coffee and tobacco, can be improved with the help of bleaching. So don't think that every kind of discoloration can be improved with the help of bleaching. So, with this in mind, we have certain contraindications, which are absolute contraindications. Don't do bleaching in patients who are having surface cracks because the hydrogen peroxide is going to penetrate and it is going to lead to severe form of postoperative sensitivity, and maybe it will lead to permanent pulpal damage. It's not indicated in situations where a patient is having defective restorations, because if the patient is having any kind of restoration, the tooth color will improve, the restoration will remain the same. So it's not indicated to bleach in patients having defective or restorations in the anterior region. Severe fluorosis or in cases of the pitting hypoplasia, it's not indicated at all. Large anterior restorations, severe tetracycline stainings, patients already having sensitivity to heat, cold, or sweets, it's not indicated that you bleach because it is a complication of vital bleaching. The sensitivity itself is a complication. Teeth with white opaque spots or white spot lesions are cannot be treated with the help of bleaching. So we have vital bleaching or external bleaching. We have in-office bleaching. The bleaching agent most commonly used is 30 to 40% hydrogen peroxide, carried in various proprietary vehicles. Every manufacturer has its own. So you must know how much concentration of hydrogen peroxide you are using for a particular treatment. So what is the chairside technique for that? This technique involves the external application of hydrogen peroxide to the tooth surface, followed by its activation. Sometimes it is activated with heat, or sometimes it is activated with light. Uh, Again, as I told you that it's only indicated in mild uh, fluorosis and mild tetracyclines and age-related discolorations. It's not indicated for every discoloration. So it starts off with the light protection goggles. If you are using any light source activated bleaching agent, application of cheek retractor is also important because it protects the lips and surrounding soft tissues. Application of tooth gingival barrier is paramount, and I will tell you in the later slide why. And then after you apply the bleaching agent and scrub it on the surface. The application time and duration is dependent on the manufacturer you are selecting.
After that, you can remove with the help of suction and reapply. It depends on the number of cycles recommended by the manufacturer. After each individual cycle, you compare the shad of the patient and then reapply according to the need. Once it is all done, we clean and we wash the tooth and remove the gingival barrier. So this is the clinical technique. I was telling you about that it is imperative to make sure that the gingival barrier is in place. Don't play with it, because due to the risk of mucosal exposure with the bleaching gel, the patient must be continuously monitored during in-office bleaching procedures. If tissue contact occurs, the procedure must be stopped and the area rinsed with copious amount of water. Gingival burns appear as whitish areas and typically disappears after a short time. Patients should be warned of this possibility before the commencement of treatment. So we are moving towards the bleaching agent used at home. Usually the manufacturers are making in the weight percent of 8 to 15% of carbamide peroxide. There is a certain problem with carbamide peroxide. It reduces the surface hardness by making it more aprismatic on the surface, as you can see in this SEM image. So it's imperative that if you are advising some carbamide peroxide bleaching agents to the patient, you also should advise some fluoride and remineralization agents, so that the patient can reverse the situation of this complication. So vital bleaching, which we are do at home, the technique involves a daily placement of carbamide peroxide gel into a custom fitted tray, or either upper or lower, and it is carried out by the patient at home and is initially done on daily basis. The technique is indicated for mild fluorosis, moderate fluorosis, and just like any indication for bleaching. Carbamide peroxide, also known as urea peroxide or urea hydrogen peroxide, spontaneously decomposes into hydrogen peroxide and urea. The 10% carbamide peroxide concentration gives approximately 3.5% of hydrogen peroxide and 6.5% of urea. So let's see in this video animation by Dr. Hamnejad Stanley, in which he is using 10% carbamide peroxide. This is the custom fit gel. We take the impression of the patient and we make a model, and on which we form this silicone index with the vacuum forming sheet machine, and which is usually you can make it by any lab after sending the impression. Once you receive it, you try to check in for its custom fit, and if you want to reduce some of the excess areas, you can remove. And this is the trick how you should apply. Do not overfill the tray with the bleaching agent. Just apply a little bit. And why? And I will show you why. Because this amount is just sufficient for bleaching purpose. When you apply, because it is tightly adapted to the tooth, it spreads itself on the tooth surface evenly. Okay, if you put extra, it will extrude into the soft tissues and may cause some tissue burns. So studies have shown that 10% carbamide peroxide can significantly decrease enamel hardness. So I have told you that remineralization therapy after carbamide peroxide usage is highly advisable. Stewards, since non-vital bleaching is not a part of conservative treatment, since it is a part of invasive treatment, because we are discussing all of the bleaching, so it's good that we should discuss this as well, so we understand what is the mechanism of action. So dark coloration of the tooth is a common outcome of traumatic dental injuries in incisors. One theory claimed that blood may be forced into the dental tubules. However, this seems to be impossible. The diameter of the red blood cell is about 7 microns. It is concave in shape, which makes it flexible and able to pass through channels 5 microns across at a pressure as low as 4 millimeter of mercury. However, the dentinal tubule diameter is approximately 2 to 3 microns at the pulpal side. However, in case of sterile necrosis, the cause is simply because of the pulp is necrosed, and because of increase in the blood flow and stagnation, and eventually to the death of the pulp. In another study, the cause is believed to be the pigments already present in the blood, which are forced out of into the dentinal tubules, such as hemoglobin and hematin, were detected in dentinal tubules of discolored teeth in some studies. In the third theory, which determines the cause of discoloration as reaction between the iron from the blood and the hydrogen sulfide from the bacterial byproducts, which forms the ferric sulfide, which deposits on the dentinal tubules on inside and causing overall discoloration. The technique which involves non-vital bleaching is indicated for non-vital teeth only, or endodontically treated teeth which have become discolored due to deposition of blood degradation products in the dentinal tubules. So what we do and how we do, we perform the endodontic treatment first, perfectly cleaning and shaping of the whole system. After that, we pack with the well condensed root canal filling for the reason of vital bleaching, and we will remove and we will obturate just below, at least 3 to 4 millimeters below the cement to enamel junction. Uh, Most of the techniques utilize hydrogen peroxide or sodium perborate either together or independently. Where a non-vital tooth has unsatisfactory root canal filling, this should be replaced with a well-condensed gut-uppercut restoration prior to undertaking a non-vital bleaching. So the mechanism is, after you place a barrier to prevent from the cervical resorption, and then we place our bleaching agent, which is in the powder form, and we mix it with distilled water and place in the pulp chamber. And the pulp chamber is sealed off with glass ionomer or resin modified glass ionomer cement. And after that, the tooth starts to lighten up. The color of the tooth is changed, and we have to replace this sodium perborate bleaching agent every 2 to 3 days, dependent on the requirement of increasing the shade. Okay, so it depends on what is the requirement of shade improvement. So what is the mechanism of action, how it's all done, whether from inside or outside? Whenever the hydrogen peroxide is dissociated and releases the free radicals, or a combination of free radicals and anions, these compounds tend to attract to electron rich alkene double bonds, and this is believed to be responsible for discoloration. And the same oxide ions are also responsible for most common complication, which is the post-op sensitivity. This post-op sensitivity in some studies is also reported by using 10% carbamide peroxide agent, and various levels of potassium nitrate and sodium fluoride showed that almost half of the participants exhibit post-bleaching sensitivity. The duration of sensitivity, if it occurred, was 3 or fewer days in 77% of the patient. Sensitivity is greatest in the first week of the bleaching, and then it declines. This study also suggested that the inclusion of additives such as potassium nitrate, sodium fluoride are effective in reducing tooth sensitivity, but not soft tissue irritation. So, talking about the two types of post-operative bleaching, sensitivity have been described generalized tooth discomfort with sensitivity to various stimuli such as hot, cold, or even brushing. The second type is the instantaneous, the type 2, which is sharp shooting, instantaneous sharp shooting sensitivity running the length of the anterior teeth, usually occurring in the absence of any external stimuli. So this is taking us towards the conservative procedure. But before we begin, let's understand the enamel as an optical phenomena. What is enamel? Enamel has various optical properties. It absorbs the light and it also transmits the light through it. And it also causes the reflection of some of the light. And the refractive index is falling is about 1.62 millimeters. So what we are doing in microabrasion and resin infiltration, which will be described in detail. In microabrasion, which involves the removal of small amount of surface with just some abrasive particles, and what we are doing, that since we know that the optical phenomena of the enamel, that it is also reflecting some of the light, it is transmitting, it is absorbing. So in cases of some subsurface lesions, whenever the light passes through, some of the light is absorbed, some of the light is reflected, some of the light is transmitted, but some of the light is scattered. The resin infiltration technique used in improving the white spot lesion. An opaque appearance of this white spot lesion is associated with the scattering of the light as it passes through the lesion body. Scattering is caused at the interfaces between two components with different refractive indices. Enamel has a refractive index of 1.62, water has a refractive index of 1.3, and air has a refractive index of 1. During the enamel air interface, large scattering is produced, as you can see in this illustration. Thus, early lesion stages need drying to be visually detected. As the resin infiltration of water is close to that of enamel compared with air, therefore dehydrated enamel would show a decrease in translucency. So what we are doing, we are modifying the refractive index of the tooth. So the procedure involves, we erode the surface with hydrochloric acid, then we dry the surface with isopropyl alcohol 96%, so it can take all the water away, all the pores are empty, and we infiltrate the resin, which has a refractive index closer to the tooth structure and which is 1.52. So looking at the clinical case, you always start off by prophylaxis with pumice and polishing paste to remove pre-existing plaque, biofilm, or any minor stains. This helps in determining the basic shade of the tooth. Next step is isolation. Then microabrasion paste, which is the brand name is Icon by DMG. You apply it, you scrub it on the surface, you wash and dry. Okay, and you apply isopropyl alcohol, and you apply a resin infiltration coat over tooth, and you may need some multiple coats to apply. After that, you scrub on the surface, and you can apply another coat. It depends on the overall outcome during the treatment procedure. Don't forget to floss the proximal contact to remove excess resin. Otherwise, once it is cured, the contact will be blocked. Now the light cure is performed to cure this resin permanently. After finishing, we have modified the refractive index to a more uniform one, as you can see in the pre-op and post-op images.
So before going to any minimal invasive procedure, the first plan is obviously bleaching. And if patient is not satisfied with the bleaching, and a lot of the cases is coming to us and with the same problem that they're not happy with the bleaching they done about few years back, so they just want some invasive and minimal invasive options. And the first thing that come into our mind is a microabrasions. When you do microabrasion, when there is a defect about 0.3 to 0.4 mm and your enamel surface involved up to that extent, so you do the microabrasions. It involves the removal of small amount of surface enamel and classically incorporate both abrasions with dental instruments and erosion with an acid mixture. So guys, in microabrasions we apply two things, and first is acid and we call it hydrochloric acid, and the second one is a pumice. What acid is doing, acid is just dissolve the enamel surface, and what the pumice is doing, pumice is basically abrasive paste to just remove that dissolved surface, and after that we improve the color. There are two main techniques for microabrading discolored hypoplastic teeth. These are the hydrochloric acid and pumice technique. I told you already that, and which requires very careful isolations. And guys, in hydrochloric acid is a very toxic chemical. You cannot work with hydrochloric acid without rubber dam. So rubber dam is a mandatory thing. And the second is phosphoric acid and pumice. And you have been using phosphoric acid during your composite restorations, and it's obviously less toxic as compared to hydrochloric acid, but still you have to go with isolations. These techniques are simple to perform, and the depth of enamel removed in 10 applications is approximately 100 micrometers. It's not like that you just apply the hydrochloric acid in one time. No, it depends on the discolorations. You can apply multiple coats, but you have to be very careful about the sensitivity of the patients. Patient might have sensitivity after one application, so you have to stop there. So microabrasion is indicated in case of developmental defects like fluorosis. There is a post-orthodontic demineralizations. Obviously, in cases of ortho patients, patients cannot brush their teeth properly, so the white spots appear in such patients, and we don't want to do more invasive one, just drill and fill it. So we have a microabrasions here. Localized hypoplasia due to infection or trauma, and what I want to say, it's idiopathic hypoplasia. Obviously, when the enamel is defective, so you first thing come into mind is the microabrasions. Then, where discoloration is limited to outer enamel layer, I told you already that when the enamel has a defect about 0.3 to 0.4 mm, then we have a microabrasion is options. When it's more than 0.4 mm, then we have macroabrasion is options. So please understand that thing. Analysis of the effectiveness of microabrasions should be delayed for approximately 1 month post treatment. Means that you cannot judge the results immediately after doing something, and please give some time to the patients, and teeth, they have to be hydrated, so the color change after a few weeks, so you have to wait for that time, because the appearance of the teeth will continue to improve during this time, so you have to wait for at least 1 month or for at least 2 weeks and 3 weeks. In that case, I done in Akhtar Said few months back. She was just 26 years old female lady, and she has something. Uh, she wants something to improve the color of the teeth, and she went to different dentist, but finally, and she also had an episode of bleaching, but the shade didn't improve. So they just visited us, and we discussed with her, and so we decided that bleaching is not successful in previous years, so we will do something more in minimal invasive things, and that's microabrasions. So you have seen the color of the teeth is a brown discolorations. The overall color is normal, but the brown discolorations is very clear in the incisal areas, and so we have to just focus on these two interiors. If you see the remaining interior, they are all fine and the color is almost normal, so we don't need to go with the bleaching, because bleach it might be the teeth get more whiter, the surrounding teeth get more whiter, so it also change the smile of the patient. So by using this technique, maximum of 100 micrometer of enamel is removed. I told you that thing before. If a satisfactory clinical outcome is not achieved, the technique should not be repeated, but an alternate treatment. I have something to say about this thing, that you can repeat that thing uh, 3 4 times and 3 times, and you might not repeat that thing again, because might patient have sensitivity. So you have to stop according to the condition of the patient. Pre-op sensibility test, radiographs and photographs are advised. Obviously, these are pre-op records, and you have to save these records in your laptop. So in future, patient visit you and want to see, and you want to see the improvement, so you can evaluate from the previous photographs. So that's why these photographs are very important to take. Then you know that after application of the hydrochloric acid, and applied 18% hydrochloric acid, we just apply here. So in that picture, it's a rubber dam isolations. So before doing any procedures, so a full arch rubber dam is mandatory. Not only it protects your soft tissues, it also protects the dentist as well, because a lot of aerosols, because of rubbing the hydrochloric acid. So your eyes can be in danger. So you and your patients have to wear the goggles, and your assistant as well. So before doing using such harmful chemicals, you have to isolate your field properly. So that's the hydrochloric acid. You can ask your dental supplier. He can provide you that thing. It's 18%. It's just a gel form. Just have to apply on the tooth surfaces, and then a pumice paste. You can also apply. You can also mix with that hydrochloric acid, and then take some profi cup or rubber cup and just rub that hydrochloric acid on the surface. So after using the hydrochloric acid and pumice, the next thing is you have to just make the surface smooth and remove all the irregularities by just rubbing a prophylaxis cup again on the enamel surface. So then you have to wait for 5 seconds and then repeat until the stain is reduced. Obviously, I told you already that you can repeat that many times, and the patient has not sensitivity with that procedure, you can repeat until the discoloration removes. So likely 5 applications per tooth is more than enough here. So any improvement, if patient wants that thing again, so you can do it again. There is not a big problem here. So guys, then after doing the microabrasions, you have to apply some resin to the surface, so that resin just penetrates the whole pores over there and make the surface smooth, and then you can polish it. There's no problem here. So that you can see that pre-op and post-op photographs, and these are all saved photographs, and if patient want to see them in future, so we have enough data available here. So the next case is also done in Akhtar Saeed Medical Dental College. It's about 6 months back. She was just 18 years old lady, and she presented to me and with some discolorations there. She went for scaling and for different dentists, but the color didn't improve here. So someone referred her to me, and then I evaluated situation here. It's a brown discolorations. The whole enamel was normal, so it was up to 0.3 to 0.4 mm defect. So we plan to go with the microabrasions. So the same thing, we apply the hydrochloric acid and pumice as a gel here. So the hydrochloric acid just dissolve the enamel surface, and the pumice abrade the surface. So it's just like a mixture one. The one is dissolving the enamel, second one is just removing the enamel here. So then after washing and drying it, we just apply the resin on the surface, and so that it infiltrate the pores if there is any pores here. So you can see situation here pre-op and what's the post-op. So patient obviously is happy with the smile, and if I don't think so she want any further improvement in future, because it's already done in a very good way. Resin infiltration alone or in combination with other minimal invasive options uh, have shown promise in masking white spot lesions. So resin infiltration is another preventive therapy in cases of white spots. Basically, in resin infiltration, what we do, we just etch the surface. We just etch the surface and we just flow the resin to just occlude the tubules there. So like that one, the black one is just like a discoloration. So basically proximal caries, and you can see in the central incisor the white spot lesions. It might be because of initial caries lesions, or it might be because of hypoplastic lesions, but in both situations we can do the resin infiltrations. But in case of proximal caries, first off you have to remove the caries, and then you plan the further about the things. So that's a contrasting picture. You just make the normal picture into a contrast form, and you evaluate the color. Basically, that's a very helpful for photographs. And then isolation obviously is a key in everywhere. So like that case is it's very clearly visible that's a high caries patient, a multiple caries lesions. So the patient might have sensitivity. So before plan of any procedure, you have to avoid all these things, and you have to restore it properly, and then you can proceed with the final options here. So guys, you can see that there's a microabrasions, and it's a pre and post op photograph. So I think we have discussed a lot about from the non-conservative to minimal conservative to the conservative option. So I hope you understand all these things, and I believe you will perform that thing in clinics as well. So guys, the show has been ended, so we will see you in future. Goodbye.